Hello, everyone, and thank you for joining this exciting session. Today, we are going to talk a bit about alcohol-related hepatitis and acute non-chronic liver failure. I'm Joanne Imperial. I am a Senior Medical Director at Fortrea, formerly LabCorp, and delighted to be working today with my colleague, Dr. Marcelo Costa, also Senior Medical Director, to whom I will turn over the presentation at this time. You will see the agenda here, which will be projected to give you an idea of the topics we'll be covering during this very short session.
Yes, okay. So Joanne, thank you for that kind introduction. This is the agenda as we mentioned in the beginning. So starting with a new nomenclature for NAFL and alcoholic liver disease. During the last liver meeting, International Liver Conference in Vienna, we had an updated nomenclature by EASL, but also AASLD and the other important global scientific societies. And now we will have the metabolically associated fatty liver disease, or steatotic liver disease, which is the new term, is called MASLD, which means that this is purely associated with metabolic disease. There will be a window of opportunity to include those that not only have that, but have alcohol intake above the 30 up to 60 grams a day of alcohol. And this is great news because talking to sponsors during the conference, we had a great feedback saying, okay, now we can explore that pathway, that combined disease, and either look into our compounds with that specific population or generate new evidence of new compounds and offer new opportunities of management for these individuals. Because we know that these are severely sick patients. They are either admitted to the ward or to the ICU. They have extrahepatic complications. And what we will see is that steroids have limited effect on managing those individuals, offering somehow a limited survival after 1 month of follow-up. And we have the backbone with N-acetylcysteine, NAC, or nutritional supplementation, which is prescribed for every and each of these alcoholic hepatitis individuals. But these are limited, and we need emerging therapies or new therapies to be explored. So we will have also those scoring systems that can predict survival, like the Lille score, the response to steroid therapies after 7 days with the drop in total bilirubin, but also MEL score. But then we will be interfacing with liver transplantation, how these patients will be seen as true candidates for liver transplant or clinical trials. So this is something that, Joanne, we would love to hear from you to explore it further. And we know that alcoholic hepatitis is one of the major entities when we go into acute or chronic liver failure or liver disease. And this is then something that will become more important after this revamp or reclassification of the now old known non-alcoholic fatty liver disease versus the alcoholic liver disease. Now they are brought into a stepwise classification where metabolically driven phenotype will be one category, metabolic and alcohol combined with it will be another category, and this opens up a new opportunity for patients, subjects, and sponsors. So Joanne, I'll give it back to you so you can explore what's in the future for us and for sponsors.
Thank you so much, Marcelo. Thank you for that excellent summary. And just another couple of words on transplantation, which certainly is an option for patients, but very few of them will actually have the opportunity to undergo transplantation due to the fact that many centers do not believe in transplanting patients that have just finished having an alcohol binge. It's very difficult to choose the patient type that will have the least likely chance of recidivism, which can be as high as 35% in some studies of patients that undergo transplantation for acute alcohol injury. In addition to those factors, there are socioeconomic disparities in that if a patient comes to a center that does not transplant acute alcohol-related hepatitis, that patient, if they have no resources, can't go elsewhere. So they, of course, will not benefit from that option. In addition, of course, we have to realize that transplantation, although it's an alternative, is really a problem insofar as lifelong immune suppression would be necessary. So obviously, we really do have to rely on medical therapy as our best option for the future treatment of alcohol-related hepatitis, and really focus on the pathogenesis, which includes targeting the inflammatory process, the intestinal barrier impairment, and of course, hepatocyte injury. There have been many failed trials thus far in alcohol-related liver disease, even with molecules that really you would think would work. Unfortunately, many of these trials failed, either because of operational issues with the ICU and difficulty with staff and allocation of detail, as well as patient reluctance, the family reluctance, and also dropout. So trials cannot be completed if a patient doesn't finish the 90-day, 6-month, even 1-year follow-up period.
Right.
So that's been a problem as well. In any event, also we've had issues now, of course, because of COVID-19. I think that more of the interesting trials are looking at hepatocyte regeneration, and I can just briefly go through a couple. In the next slide, you can see that there are many different targets that are being considered, but obviously because of time, we can only address a couple right now. Very interesting is the concept of granulocyte colony stimulating factor, which has been looked at in several trials. Initially, this looked very promising, in particular because of success in India with several trials. But several trials done in the US, initially smaller trials with 30 to 50 subjects, and ultimately our larger multi-center trial failed to validate the findings that were found in India, where they did show improvement in liver health and function, as well as survival. This was not borne out in studies done in the US, where there was no significant statistical improvement in survival or infection rate at 90 or 360 days between GCSF alone or GCSF in combination with placebo.
Right.
So that's discouraging. However, we have other options to consider. A new one, which is quite interesting, is that of epigenetic regulation in alcoholic hepatitis. This has been recently discovered as a form of inhibition of DNA methyltransferases, which apparently are upregulated in alcohol-related liver disease, and it's an attractive new approach to the disease. The methyltransferase inhibition will actually impact lipotoxicity, cell death, inflammation, and hopefully lead to improvement in liver function, liver health, and survival. A very interesting phase 2A short trial with small number of patients using the direct 928 molecule known as larsucosterol, I hope I said that right, and showed that all of the subjects left the hospital in 28 days, so all survived, most of whom only had 1 dose of the compound. Now a large phase 2 trial, which will enroll about 300 patients, is scheduled to complete enrollment at the end of Q2 of this year, and we were looking forward to possible results, maybe even by the end of the year. So we'll see about that. That should be quite interesting. given the high cost of transplantation and the low availability, I do think that medical therapy is really going to be our future. And unfortunately, we do not have good experimental models for alcoholic hepatitis.
Right.
So animal models are desperately needed, and data obtained from these models really will be essential in order for future research to be successful. I do have to say that although we've been disappointed by the GCSF data, there are other exciting potentials, including stem cell therapy, that are being explored by some sponsors. And stem cells might be a little bit easier to use in this disease, and could be really a good way to target liver regeneration. It's an innovative technology, although so far evidence is scarce, and we just need more data. We need more trials. We need to encourage these trials to occur. So, in summary, I just wanted to say that we have not made that much progress yet in this very devastating disease of alcohol-related hepatitis, which leads to acute on chronic liver failure, complicated by sepsis and renal dysfunction, multi-organ failure and death, unless transplantation occurs right now, again for a limited number of patients. But we look forward to the future, and thank you so much. And thank you again, Marcelo, and take care for now.